Hi, welcome to Demystifying the Coccyx, Gentle Effective Treatment for Tailbone Pain, a science-informed approach. I'm Jerry Hesch. Got a bachelor's in physical therapy long ago, went on and got a master's of health science at Krannert School of Physical Therapy in Indianapolis, and then a clinical doctorate at A.T. Still University in Arizona. Our sponsor is PESI Rehab. I've been working so hard on this presentation. We have like just under 80 references, and I think the handout is lots of pages. Looks like it's about 70 pages and lots of graphics. My goal is to make evaluation and treatment of this interesting joint straightforward for you. I believe in simplicity. All right, scope of practice. Materials that are included in this course may include intervention modalities that are beyond the authorized scope of practice for your profession. As a licensed professional, you're responsible for reviewing the scope of practice, including activities that are defined in law beyond the boundaries of practice in accordance with and in compliance with your professional standards. Conflict of interest disclosures. As required by several accrediting boards, speaker and activity planning committee conflicts of interest, parentheses, including financial relationships with ineligible organizations, end of parentheses, were disclosed prior to the start of this activity. To review disclosure information, please see activity and advertising. And I have no disclosures other than say I work for Hesch Institute. I treat clients and I develop online course material, and once in a while teach an in-person course. All right, introduction. This presentation consists of lecture via PowerPoint, and there are links to video demonstration, but they are not inside the PowerPoint per se. You're not going to view the videos while looking at this PowerPoint. And there is also a handout, and the PowerPoint follows the handout quite nicely, and lots of images and live links in the digital handout, okay? Actually, I did go through this PowerPoint, so the next sentence doesn't really apply. We did put all of the references inside the PowerPoint also, but they're also in the handout. There are a few within the text, and then at the very end, we have a list of references that is almost 80, if not 80 at this time. Okay. Coccyx used to intimidate me, and yet I, long ago, early in my career, I started to treat it, but rather ineffectively. Treating the coccyx can be very rewarding. The client does not have to be aware of local symptoms in order to derive benefit from evaluation and then treatment. Why? Well, the goals of treatment are to reduce or eliminate nociception, restore normal muscle tone, restore normal neurology, including resolution of muscle inhibition, reduce nociception, the distal compensation. So in other words, you have an injury in your foot, you're going to compensate up in the upper cervical, and that's driven by the writing reflex. We can't overwrite it with exercise. You have to treat the cause, the mobility impairment down below, and then the compensation usually just melts, okay? And we want to restore normal mobility and stability. And going back to the client doesn't have to be aware of it. What that means is that a lot of clients don't know that they have a tender tailbone, okay? They don't touch the tip of their tailbone, they just don't do that. And so when you do a evaluation and you palpate that area, it's like, oh, that's sore, and that might be new to them. That's what that meant. All right, next paragraph. When a joint has blocked mobility, there's increased tone in muscle, tendon, ligament, and capsule in one part of the joint, and the opposite occurs in the opposite direction. But of course, movement and restrictions are three-dimensional, not necessarily only in one plane of the body. All right. Muscle tone becomes inhibited via facilitation of the Golgi tendon organ and a very similar type of nerve that are in ligament and capsule called the type 3 mechanoreceptors. They're in ligament, fascia, and capsule, okay? So when you have an injury and you get a loss of micromotion and a mild malposition, which may or may not be able to discern it visually, but you can feel the blocked mobility. When you encounter that, this phenomenon will happen, and there will be inhibition of muscle function, inhibition of normal muscle tone. All right. The inhibition contributes to hypermobility in at least one direction or several. And when you restore mobility, it improves muscular stability by resolving the neurological inhibition, and apparent repositioning may also reduce the hypomobility. Difficult to research that micro movement that you're restoring, that micro positioning, very hard to objectively measure that. Works well in big joints, but smaller joints, challenging. So that's a basic principle of the Hesch treatment paradigm, which is to find restrictions of micromotion and movement, okay, and then restore that micromotion, evaluate the distal compensation, and do a normal PT evaluation, strength and sensation and such, and then retest after treatment to see if there was muscle inhibition that then resolved, okay? So we're going to go through terminology. I hope this is helpful to you. Okay. So the experts recommended that we refer to the coccygeal segments with the following nomenclature. CO1 would be the first coccygeal segment that attaches to the sacrum, and then CO2, etc. Okay. So we don't call it C1 because C references the cervical spine. So we have to add the letter O because it's coccyx. All right. AP means anterior to posterior. I think we all know that. A couple of terminologies for coccyx pain, and one is coxalgia, one is coccydynia, and one is coccygodynia. They all mean the same. So what is a coccyx? Well, collectively refers to the unitary structure, which is typically comprised of 3 to 5 bones, but varies in both directions. There are exceptions, outliers. Because one or several segments may fuse, it can also refer to the cluster of fused coccygeal bones, which may or may not return mobility at the sacrococcygeal articulation. Okay? Now, when we reference movement of the coccyx, we are referencing the movement at the sacrococcygeal junction, unless we state that otherwise. There are small movements in the intersegmental parts of the entire coccyx structure. We make brief mention of that later on. There's a lot of variation in form, and Foy is a very good reference. And he suggests that regarding terminology, rather than calling it a coccyx, a better terminology would be tailbones or coccyx bones or coccygeal segments. Okay, so direct technique, what is that? Direct technique is, as an example, my dresser drawer is closed. I need some socks. I directly open it, get the socks, close it. All right, that was direct. Let's suppose that I'm trying to open it, but it gets stuck. Usually a little bit of obliquity, okay? So it's impossible for me to keep trying to open that dresser drawer. And if I close it and then I open it, bingo, it goes beautifully. So I'm sure you're all familiar with strain, counter strain, positional release, those sorts of techniques that are indirect. My approach is direct. So if I find a coccyx that doesn't spring from the left to the right, then I treat it that way to restore that left to right spring mobility. And it's very effective in the tailbone. I know some people that treat it indirectly actually exaggerate the malpositioning and For some, that releases. That's kind of my secondary approach. Next term is dislocation. That is a discontinuity in a joint in which one bone has slipped or rotated, twisted in relationship to the other one by more than 25%. The site of the most common dislocations is sacrococcygeal. However, any of the coccygeal segments can dislocate. Not all trauma to the tailbone are purely vertical. So when people fall on their bum, that's a vertical, and an anterior induces more forward flexion. But sometimes someone can have a blow to just a coccygeal segment. Let's suppose I fell backwards onto the corner of a side table next to my sofa and struck one of the intersegmental joints. Then I can traumatize that, create instability there. And you'll see a little bit more on that later. But most mobility impairments involve the sacrococcygeal joint. And of course, variation in anatomy and variation, shape, and angulation come into play with injuries. See figures 1 and 2. All right. So this is a dislocation. So this person has, we'll call the top one the first coccygeal segment. So in this example, the second one is dislocated, and the third and fourth segments just go with it. So we don't call it a CO3, CO4 dislocation. We call this a CO2 dislocation. It can also be called a listhesis, an anterolisthesis, because it slipped forward. So in order to be called a dislocation, the discontinuity of surfaces needs to be 25% or greater. Otherwise, it's called a subluxation or a luxation. Okay. In the prior image, let's go back there. You can see that's more than 75% asymmetry there. So that definitely is a dislocated joint. Okay. If it's only 25%, then they call that a subluxation or a listhesis. Okay. Other terms are a hyperflexion. Anyway, let me catch up. I'm not sure I had that statement for our purpose. Will be just, I think I had another image when I said it would be described as 30%. So kindly ignore that. And a comparison of a standing and sitting x-ray may demonstrate instability that can otherwise be missed with a single lateral x-ray. So we'll come to that x-ray protocol later on, okay? We're still in terminology. And here's a image of a fracture at the very top. The CO1 segment has hairline fractures, but no displacement. But then if you look down at the second coccygeal segment, it is completely fractured and displaced, okay? But we need to be cautious in our communications and in understanding the other person's perspective, and also regarding writings, because strangely at this joint, when there is a displaced tailbone, a fair number of clinicians refer to that as a dislocation, when in fact, sorry, let me back it up just a little bit. Yeah, they call it a fracture. I'm sorry. Yeah, a lot of them refer to a dislocation as a fracture, which is not really semantically true. So don't know where that terminology came from, but just be mindful, you know, is it a bony fracture or is it a dislocation at one joint? Okay. All right. I think we all covered this. And we already discussed the fracture and had a nice image. Now we'll discuss hypermobility. So as soon as we sit down, if we're weight bearing on our tailbone, oftentimes the coccyx then goes into a little bit more flexion, but it depends on your posture. There are some postures where it actually pushes into a little bit more flexion. So some variation based on anatomy and prior trauma, etc. Okay. So hypermobility is best demonstrated in the sagittal plane with a lateral X-ray, and then a sitting X-ray, and they are compared. And we'll show you a graphic of that, okay? An immobile coccyx with a sitting, standing, lateral X-ray, there would be a movement of 5 degrees or less. That okay? We talked about indirect technique already. We'll talk about lateral deviated coccyx. So in the literature, you may come across the term, excuse me, side bent coccyx or lateral deviated coccyx. Okay. And you need to clarify the terminology, because sometimes they look at the tip and the tip points to the left and they call it left side bending. But in orthopedic manual therapy terminology, standard biomechanics, a right side bent tailbone, the C1 segment drops down on the right. It's the one with the transverse processes, becomes lower than, and the tip of the coccyx points over to the left. So the terminology can be a little bit confusing. You need to know what the person you're dealing with, what is their intent. For many years, I used the wrong terminology, and that's most unfortunate. And I have still some YouTube videos that have the wrong terminology, so I may pull them later on. Anyway, we'll get to my terminology, and it's a little more clarifying. Okay, all right. Next terminology is normal coccyx mobility. So coccygeal mobility of 5 to 25 degrees based on lateral view in sitting and standing. Okay, I'm not aware of any reported norms for side bending and rotation. Very few clinicians are aware of side bending and rotation. There are only 2 imaging studies in the literature on a side bent or laterally deviated coccyx. I couldn't find any imaging studies on rotation of the coccyx, but treatment technique has been described on treating rotation. I think the first one was James Manel in 1952. All right. PA is a biomechanics terminology, and it means posterior to anterior. Okay, I see my typo there. Weird, I ran spell check and I missed that OD. All right. Right side bending and left rotated coccyx with tip pointing left, lacking left to right mobility. Okay, so it doesn't side bend back to neutral, and lacking left CO1 PA spring mobility. So that's really quite a mouthful. The last statement is respecting the lack of rotation when you're pushing anteriorly on the left side of CO1. So I don't think we have the perfect terminology down yet, but I like it better than simply saying, I watched the Nuggets win last night. Oh, well. Anyway, so yeah, it can get confusing if someone just says side bent coccyx or use the wrong terminology. They see the tip pointing to the left and they say left side bent coccyx. So we can say a little bit more about it. It tells us what we need to think about for treatment, okay? And so if you use a similar terminology, You should be able to convey the positioning. The tip points to the left when I look at it from the front, or with an X-ray. It lacks this passive spring mobility when I try to spring it to the right. But when I come to the right, there is movement there, okay? And then when I come on the back of the first coccygeal segment and I try to spring it on the left side, this is my left thumb, it lacks mobility, but when you come to the right side, you can actually make it rotate a little bit further to the left. So it's a bit of a mouthful, but I think it's a lot more clarifying. And it also tells you, well, gee, my goals are to straighten out the coccyx, straighten out the rotation, and also to restore spring mobility going from the left to the right and springing left mobility when we spring forward on the left side of C1, such that it could normally rotate. Okay? That will be repeated. Okay. Terminology continued. I think we already said this, so I'm going to go down to the lower portion. Yeah, we discussed this already. Okay. Terminology continued. And that's more the first paragraph I'll skip. And I'm talking about spring test now in the middle paragraph. In this model, which I started to develop in 1981, I described a normal physiological property of joints and connective tissue. Okay. There is a manual therapy, orthopedic manual physical therapy tradition in which a bony structure is contacted, and then you push it in a specific plane of the body, you push it in a specific direction, and you push it until it stops moving. And that's called taking up the slack. And then you thrust it, okay? And there, the Hesch model tells you how much force to use with those tests. The traditional model can be a little less precise. I did measurement studies in approximately 1990, learning how much force the average pelvic structure, be it an ilium, an ischium, a pube, a coccyx, how much force the average, cluster of 20 subjects, what those forces are. And so I teach measured forces for doing that test, okay? So in the traditional model, they take up the slack and then they give it a thrust and they grade the mobility based on that thrust. And that's so counterintuitive to me because the joint should also recoil. And when I read in 1981 that the sacroiliac joint functions as a shock absorber, then I thought, oh, well, I'm going to go test it the way I test my shock absorber in my truck. I push down on the fender, taking up the slack to a stop point, and then I give it an extra thrust of approximately the same amount I use to take up the slack. If it's a good shock absorber, I'm going to be able to depress it without it clunking. It gets firm, okay? And then I add the spring, and it also will bounce back. So I don't spring and let go. I spring, and I pause just a little bit and let it push back into my hand. Okay, so that's the difference. You really want to own the spring test. We do repeat this a little bit later on. Okay, so grading is more simple in my model. I can go a little bit crazy with all the different traditional grades, but I question, can someone really tell the difference between subtle grades of motion? And I submit that most can't, including me. So I use a 3-point grading system. It's normal. I can take up the slack on this structure. I can spring it forward and it recoils into my hand with integrity. Okay. So it feels similar with the forward spring and the backward spring. Okay. Or it could be hypomobile. So it may be the case that you can't take up the slack, or it may take up very quickly. Okay. And then you're not able to spring it. And the terminology I use is hypomobile. Unless If I have a different meaning, I will clarify that. But when I say hypomobile, it means blocked. Okay. And then hypermobility, meaning distinct. And that you would discern when you load a joint and it just keeps on loading for a little while. You know, you get the sense like, wow, that's weird. And then when you do the spring test, it's a greater excursion than someone than with a normal joint. Okay. And then when you load it, you spring it, when it's supposed to recoil, it just kind of comes back slowly. It has a mushy feel. And I know that's subjective by hearing about it, but once you've tested several bodies using that technique, it'll become second nature. Very distinct difference between these three. All right. Okay, so I don't worry about the lesser grades. I don't say, well, that's a little hypo, that's a little hyper. No, I don't worry about that, because those kind of hint that there's some dysfunction somewhere. But if I go find the direction or directions that has a distinct lack of mobility, then when I treat it and restore that mobility, I get the biggest bang for my buck. Okay. Okay, now we're going to move on and talk about function. So the coccyx serves as a point of weight bearing, forming a tripod with the ischial tuberosities in sitting. But of course, it depends on what surface you're on. If you sit in a bucket seat, you're going to weight bear on your tailbone. Same for a soft sofa. In my truck, I sit more upright, and I can easily slide my hand under my medial buttock and not touch the tailbone. For me, that's more comfortable. Okay. It serves as an attachment site for the filum terminale of the spinal dura, serves as a site for attachment of ligament and pelvic floor attachments, which of course is muscle. It moves a little bit to assist with defecation. It moves into extension, increasing the AP dimension of the pelvis during childbirth. Okay. Not so much during pregnancy because the baby is up in the upper canal, but once they come down in that lower canal, then this can happen. Let's talk about movement. The coccyx typically flexes and extends, but with a passive force, such as a fall onto the buttock, it can move into different directions, such as side bending and rotation. The joints can get compressed vertically, and that's a very small movement, but when treating it internally where you can clasp it, you do want to do a distraction. Okay. Distracting any joint can be so very therapeutic. Flexion and extension, or flexion with return to neutral, have been studied via sit and neutral position, like standing or laying sideline x-rays. Coccyx mobility has also been evaluated with bowel function studies. Side bending and rotation motion studies could not be encountered meaning clinical studies. So I did not find studies that show a pre and post change in response to a clinical intervention. Those are lacking. We need good clinical studies. I did actually find 2 imaging studies. In one population, 30% of them had a side bent tailbone. But because it wasn't a clinical study, we don't know what the true mobility in that structure was. Let's imagine that someone had a developmental side bent tailbone, so it was made that way. I still think it would have spring mobility in both directions. Whereas when you have a traumatic force and it pushes it into end range, then it lacks the ability to spring in one direction. In the other direction, you can enhance that positioning, that direction of mobility. And because there hasn't been much in the literature, some clinicians believe that it's non-relevant, which is really most unfortunate. We simply need more data. We need clinical data. And some believe, well, we don't have published studies, so it's not relevant, so I'm not going to evaluate and treat that in my clinic. And that's a rather strong stance. And there are knowledge gaps in orthopedic manual therapy. There are knowledge gaps in everything, and our effort should be to fill those. We're going to talk about developmental bony and bony anatomy. There are many anomalies, such as partial or complete fusion, which can be unilateral or bilateral at the first segment, in which the disc base gets obliterated. There's a disc between C1 and C2, or involving one or both of the sacral cornua, which some people refer to them as facets, but I'm not sure that's a proper terminology. They can have different shapes, but sometimes they will bridge and fuse on one side with the cornua are little projections, and the sacrum has cornua also along the hiatus. Okay. So there are some cases where the transverse process actually fuses to the sacrum. We're talking about the transverse process, which is only at the first coccygeal segment. So those are interesting. So the mobility testing, they would have lower coccygeal mobility, but not at the C1 segment, okay? Mobility at that joint can vary from person to person. Here is a classification, but let me back up a little bit, okay? If you evaluate someone and you discern that their tailbone is side bent, and yet it doesn't spring on either side of the joint, that probably is a fused structure. When there is a lateral deviation or side bent tailbone, you can usually actually spring it and enhance that positioning, but you can't spring it back to neutral without a protracted passive force. It's not a joint that we want to manipulate. It's not a synovial joint. We want to impart a passive force and stay there. We'll cover that later on. Okay, so sacral and coccygeal anatomy. This person has 5 sacral segments and 4 coccygeal segments. The top image is an X-ray. The bottom image is a CT scan. As you can see, the CT is more clear. These are from Skalski, and there are actually some images in his study, in his publication, that I did not include in the slideshow. I strongly urge you to chase that article and thumb through the pictures, and if you're inclined, read it. I forgot in the introduction to mention that I'm very accessible. Should you have any questions, I am absolutely accessible. PESI Rehab has a place where you can interact, you can pose questions, and I typically answer them within 2 days, okay? Whenever you see a lot of text, as you're following the PowerPoint, you go, there's a lot of text there. It's worth glancing through there and see what's necessary. If there's an abstract, I would like you to read the abstract, okay? So I've sort of lost following the handout with this presentation, but I'm going to flip some pages and get caught up. Good. Very good. All right. So I'll do a better job of flipping pages, all righty? So this is a categorization of different types of sacrococcygeal joints. And that's not something that you have to memorize. Just be aware that there are 4 different types of sacrococcygeal and intracoccygeal anatomy. Shape. Okay, this image shows you see the green there on the top on the left side, which is an anterior image. That green thing is the site of attachment of the fibrocartilaginous disc, which connects C1 to the bottom of S5. And if you look at us underneath the S5 in a future slide, you'll see it's very much oval shaped. And the top of the coccyx is named the base because it's wider. So just think of it as being an upside down triangle. The base is up on the top and they both taper down. Here's another image showing you the sacral hiatus. That is one site where they can do some blocks. Some blocks are done lower, and we'll show you where later on. And you can see that in this person, the sacral and the coccygeal cornua, spelled C-O-R-N-U-A for plural and C-O-R-N-U for singular, do not really connect. Okay, sometimes they form a joint. When they do that, they oftentimes are referred to as facets, but not always. Okay. And this critter has how many coccygeal segments? 4. Very good. And then notice on the left, you can see that it points to the transverse process, which is so rudimentary at C2, somewhat rudimentary, somewhat, let's just say it's short. If that was a cervical vertebrae, it would be a lot longer. Let's say that. Okay, another view. Here's an anterior view. And at the bottom, you see that oval process there. It's somewhat narrow. And that's where the coccygeal disc connects sacrum and coccyx. Okay. A few more landmarks, but you don't necessarily need to know them. All right, here's another image. Now, if you look at that disc, okay, you get the impression this is a developmental asymmetry. This is not traumatic. I submit to you that if this person was in your clinic and you want to test mobility of his coccyx, when you contact the left side of the coccyx and you try to spring it to the right, I suspect there would be some movement, okay? When you go in the opposite direction, springing from the right side to the left, simply because the disc looks a lot more narrow on that side, I think that the mobility would indeed be less, but a little bit of a softer end feel, okay? And this guy clearly has deformation higher up, just kind of peculiar anatomy. You'll notice the difference in the shape and length of the transverse processes of C1. Okay. And then here's a view of pelvic ligaments. And you just want to become aware of the ones that attach to the coccyx and just appreciate the pelvic ligaments. You also want to be aware of the sacrospinous ligament, which you can actually palpate and check the tone of it right above the ischial tuberosity. It spans up to the bottom of the sacrum, and in that midpoint, you can load it, pushing it forward and then spring it and determine, does it spring? I think it's normal. If it doesn't spring, it's hypo and something needs treatment, okay? All right. And here's a posterior image, and it shows the smaller ligaments. In terms of clinicians, I don't think they play into our manual therapy unless we identify a source of tenderness or unless we identify some weakness. And sometimes you can palpate a ligament and discern that it's more lax. You can do a little AP spring with your thumb, but not all of them. And if you suspected gross instability, your spring test on the bony structure would be excessive, but also when you spring the ligament, it would absolutely act hypermobile. Okay, good. Next slide. Similar slide here, you see the sacrococcygeal disc, and you see a little bit of disc in the segment below that. And then on the last segment, you don't see any disc. So those lower two segments are most likely fused, and you see a bit of the intercornual ligament. Okay. Again, when you encounter an abstract in the handout, please do review it. And there is an abstract, and it has to do with the histology of the fibrocartilage. And I think that it has a very distinct histology. There's 4 different types of fibrocartilage, and I think that the sacrococcygeal coccyx allows for the greatest mobility, so it may have a greater degree of elastin. Okay, now we're into neurology, and we have some good graphics, and here's a link to some videos. But I would add that these links, that video is an excellent overall review of coccygeal anatomy. So you might want to watch the whole thing. So interesting how the dura comes down to a point just below the first sacral segment, and it continues down. It attaches in the canal at that level. It also attaches way up high at C1, C2, and then of course for foramen magnum. All right. The dura extends on down all the way to the tip of the tailbone and blends with ligament down there. Okay. And it anchors the thecal sac. Another image, you can review your anatomy here. Review that the cauda equina is pretty high up at about SL1. And then everything else that's coming down below is nerve roots. It's no longer spinal cord. Okay. And then you want to gain an appreciation of where the coccygeal nerve is. Okay, very good. And then here's another nerve image. And on the front, in the image on the right, you see the sympathetic chain, which comes together down below in front of the tip of the first coccygeal segment. And that is the ganglion impar. That is a common site of injection. And if you look at the first listing, it is another image of the intercornual ligament. And then below that, it says usually fused. So just have an appreciation for the coccygeal nerve, the ventral rami, and then also of the dorsal, okay? And then at the very bottom is the anococcygeal nerves. And then don't forget the pelvic floor. What a remarkable structure. Many layers of the pelvic floor. And there's some good data on treating the pelvic floor. It does make a big difference on a certain subpopulation of people with coccygeal pain. So at least be familiar with the pelvic floor, okay? And then here's another image, gives you a little bit better visualization. Blank screen. Now we should come up on an abstract pretty soon. So this shows the attachments of the gluteus maximus onto the sacrum and onto the lower sacrum, the ILA, and the coccyx at all of the lateral portions of the segments, okay? We're now going to talk about symptoms. When someone has an injury, how do they present? Okay, and there's a paragraph there in the handout that you do want to read. And typically people with coccyx pain, they have local pain. They might have trauma to other proximal areas, proximal nerves. The pudendal nerve might be injured, and then they may have sensitivity around the genitalia. It's a very complex anatomy where lower thoracic, upper lumbar also blends with lower sacral nerves. Very interesting. Let me catch my thoughts for a moment. So anyway, they may have proximal pain very close to the tailbone, but also in the surrounding ligaments and surrounding soft tissues as well. Pain is common on upright sitting and when leaning backwards because you put a little bit more weight on the tailbone typically. If the tailbone is injured, people have pain going from sit to stand. Now, when they're standing, they're using their gluteus maximus to, extend hips and extend pelvis on spine. You recall that image where the fibers attach onto the coccyx. So it makes sense that that could be painful. Now, interesting, it can decrease when sitting on a toilet, and it can increase with sexual relations. Pelvic floor pain and dysfunction correlate very strongly with coccydynia. I like to refer my clients for a few visits with a pelvic floor therapist after I have done my coccygeal mobilization and find it to be stable, okay? And sometimes I'll say, well, I just had pelvic floor therapy and last week. And I say, well, now that we've established normal mobility, there should be more balance in the local neurology, less hypertonicity on one part, less hypotonicity on the opposite part. That's a general example. So at that point, maybe 3 visits of pelvic floor work. What causes coccydynia? So most of these come from Goodman and Snyder's book, and they quote a couple of authors. And here there are, but don't assume that this list is complete. All right, and I'll just name them off rather quickly as I sip some water. Okay. Anal fissures, anal intercourse, cancer, childbirth, chordoma, neoplasm, cyst at the tip, discogenic disease or herniation, any form of disc disease, a tear, an annular tear with local inflammation, degenerative spondylosis or spondylolisthesis, developmental hip and or pelvic asymmetry, including a lateral lean and sitting. And a lot of people sit asymmetrically because somewhere in their body they're uncomfortable. And the very act of sitting in tailor sitting, that figure 4 position with, say, right heel on top of left knee, that induces asymmetry of how you weight bear onto your buttocks. So if they do that for a long time, that may induce some coccydynia. Ehlers-Danlos syndrome is hypermobility syndrome. Fracture dislocation, hemorrhoids can be a source of proximal pain. Hypermobility, which is Ehlers-Danlos requires a specific genetic test. Hypermobility syndrome is not as severe. Infection, inflammation, spondyloarthropathy, I think we mentioned already. Lumbar spinal stenosis, neurofibrosis, non-union fracture of the sacrum or coccyx, obesity, sacroiliac joint dysfunction. You're going to learn a pattern of that I stumbled upon quite some time ago. It's 6 different patterns in the lower pelvis, and they promote side bend tailbone. And sometimes when you restore mobility in the lower pelvis, I just lost my thought. Okay, so sometimes when you restore mobility of position and mobility of the lower pelvis, the apparent side bent coccyx straightens out. Same with the rotation. You don't need to treat it directly. Other times it remains and you need to treat it directly. I don't like the term sacroiliac dysfunction. You can find YouTube video where I discuss that, and I defer you to those. Okay, pilonidal cysts, pregnancy, prostatitis, repetitive stress. So one example would be what I think is the biggest cause of back pain that people don't even realize, and that is getting in and out of a chair or a car in a hurried manner, and doing so in a manner that uncouples the trunk and the hips and pelvis, or if there's excessive rotation. And in the handout later, I'll give a link to a video on ideal body mechanics, and we go over what's the best way to get in and out of a car, okay, to reduce those stresses. A sacrococcygeal disc injury, certainly. A sitting posture with excessive posterior weight bearing, such as in a bucket seat or in a soft, low sofa, okay? Seat height is so important. If you could change only one thing in someone's sitting, it would be to make sure you optimize the height of the seat surface, so that they can easily roll their pelvis back and forth, tilt it side to side, easily change their position. That's what you want. You don't want to stick them in an ideal posture and then stay there for 2 hours. It no longer is ideal. Okay. If they're tall, they should buy a taller gas cylinder than the standard one that comes with office chairs. Now, you will read people referencing somatization disorder. I first became aware of that term. It was about it was in the late 80s. Somatization disorder, in which someone's stress expresses itself as somatic pain. I'll defer you to a bigger definition of that online. So, or psychological stress has been mentioned as the cause for coccyx pain. And it kind of bothers me. I'd hate to label that on anybody. I would rather say that it correlates with it. In fact, coccygeal pain and dysfunction can cause the latter, okay, can contribute to stress. But I sort of hate it when people say, well, I'm not going to put my hands on you because all pain is in the brain and you just need counseling on how to manage your pain and manage your stress, and then your pain will magically go away. And, we're starting to see some shift in the tide. Everybody jumped on the biopsychosocial model, which reduced a lot of the bio aspect of it. And peripheral nociception is a very, very valid concept. That for a while was not getting much respect. And maybe 2 years ago, there's a great article in the Physical Therapy Journal on nociception and specifically peripheral nociception. Okay. So I just urge caution with that, with the interpretation when you're suspecting that someone's pain may be psychogenic. Maybe the story will play out, and maybe it's not. Okay, Tarlov cysts. Those are fluid-filled small cysts, or they can be large, that are usually found, if they're present, they're found in the sacral canal. I've seen some reporting of them in the cervical. Excuse me, not aware of any in the thoracic and lumbar region of the spine. Okay, the next cause would be teratoma, a type of tumor, typically encountered in newborns and requiring, quick surgery. Trauma such as a fall or a innocuous torsional injury. Okay. End range twisting, not good for low back and coccyx. Thrombosed hemorrhoids, weight loss, reducing padding for sitting. In other words, the person is a heavyweight and they quickly lose the weight by undergoing a surgical procedure or medication, diet, and exercise, yada, yada. Okay. So they suddenly have lost 40 pounds and now they go to a restaurant and they only have one type of chair and it's a hard wooden chair without padding. And then they sit and that can be painful onto their tailbone. Infection. You always must do a visual inspection of the anatomy. You want to look at the outside of the sacrum and look at the top of the gluteal cleft, which is a common site of pilonidal cysts, which sometimes have to be lanced and drained. Okay, but anyway, here's a wonderful educational video from Dr. Foy. It's titled, "Do you have a pilonidal cyst or is it coccyx bone, tailbone?" And then there's the link. Well, I should have moved this slide up, but it is what it is. The role of Tarlov cysts in pain and nerve impairment is controversial. It's important that you're at least familiar with Tarlov cysts, and there's video and there's some, I think there's at least one abstract in there. I'll double check that in a moment. There is reference to an abstract that you could read, but I don't see the abstract copied in the handout, okay? So you should be following all of these slides with the handout, okay? All right, so Tarlov cysts are nerve root cysts, which may contribute to pain and dysfunction. They are best visualized with an MRI, but their role in symptoms is controversial at best. Some people drain it and then they fill it with something to facilitate scarring, okay? Some people have it surgically removed, and I believe there's mixed results. And I had a patient, and you never know it, but she was a federal marshal. So if you get on an airplane, if I ever see her there, I'm like, okay, you're the one with the gun. But she had a surgical procedure, and her doctor used her as one of the cases in his publication. And he overstated her gain from the surgery. He had a bias on that. And when I read the good results, I was a bit skeptical. I'm like, 80% maybe, 70 more likely, 100 no. But anyway, she was not happy that she got, her case got published and they reported very good benefits. It's like, no, she got moderate benefit. All right. Yeah, so it's still controversial as to whether or not treating them is effective. It's fluid filled, but is that necessarily space occupying? Can it really impinge against the nerve root, or does it just flatten out a little bit and stress the forces? Those are valid questions. Okay, so here are two images. The section we're in is hypermobility and stability, dislocation and fracture. And so if you look at that top image, there's a little bit of an osteophyte there, I would say, but actually it's a fracture. It's a displaced fracture. It's a little bit difficult to perceive that, okay? Now, in the next image, you see a slippage, and I'll just call the slip segment C1. I do believe that is C1. And you'll see that it glided forward. It's almost impinging at the bottom of the ILA of the sacrum on the right image. And at the bottom, you can see it was kind of a pure anterior glide fixation of the first coccygeal segment. Whereas if you follow the curve of the next three segments, it's a little bit it's pretty grayed out, but you can make it out. And you can see that they maintain their symmetry. That's an interesting case of only one segment seeming to be subluxed. All right. Let's go down and see what it reads. Now look again at that arrow on the left side. There is the smallest little piece that fractured off. Okay, so figures A and B, coccyx fracture in a 22-year-old woman with coccyx pain after a fall skating. Yeah, ice doesn't give very much, does it? I'd rather fall on water than on ice. And I tell you, it's not the acceleration that'll harm you, it's the deceleration. If I could change it, I would. I had a motorcycle wreck, so I speak with authority. All right. A lateral radiograph shows mild anterior subluxation. We're referencing the prior slide of the first coccygeal body with a subtle small fracture fragment anteriorly. See arrow. B, a lateral radiograph obtained a month later. What happened? Look at her. Look on the left and look on the right. Clearly, it's further slipped. The C1 segment, CO1 segment, is slipped even further forward in relationship to the sacrum. And to me, that looks like 30% or more, not quite 50%. And then on the, okay, so the first one shows mild subluxation of the first coccygeal body. And there's a subtle small fracture segment anteriorly that the arrow points to. Okay. And this person, of course, would have discomfort in the acute phase, especially with sitting on something soft or sitting on a bucket seat, which they're putting more stress through the coccyx. I would expect them at that time to have more discomfort. The person on the right would even have a greater, if their nerve systems are equal, the one on the right would have a greater amount of discomfort, obviously, because there's a greater listhesis there. Okay, so the first one showed us tiny fracture segment at the front, and it showed an anterior subluxation. The second image, B, was obtained a month later, and it showed progression of the CO1. There's a typo. That should be CO1, not CY1. I'm just taking notes, clean that up. In B, it was done a month later. Why does it show extension, further migration of the CO1 segment anteriorly? Why is that so? Let's go back there. Okay. And if you follow the curve going to the front of the lowest coccygeal segment, okay, and then you follow that curve again, you'll actually note that there seems to be a slight retro positioning of the C2 segment. The C1 very subtly displaced anteriorly. Okay, let's go. I think I had another thought. But sorry for my typos. I at the bottom sentence there on the left, it says CY2, and that should be CO2. And then two sentences above, it should be CO1, anterior subluxation. Sorry about that. Okay, my goodness, look at this. I wouldn't want to be this guy or gal. And this person certainly had a traumatic fall. So you look at the lumbar spine, you can see L5 down there with a big disc. Okay, I wish mine was that pretty. Then we have an S1, S2, S3, S4, and S5 that are pretty challenging to make out. The lower two are kind of tricky, but then you can see a distinct dislocation, instability of these C1 segments, okay? And then you look down below that, and it seems like the C2 also is also moved, but I think that we would refer to as a luxation or a subluxation. Didn't move as far. Okay, what about imaging? We've been yammering about it plenty. You know what disappoints me is to have someone come to see me and they have severe and lasting coccyx pain. And you ask them, well, we, before a patient comes, we literally screen them. We send them 11 pages of paperwork to fill out. And we ask them for the imaging itself, and the imaging report is very important. Find the report. So they'll sometimes give you a CD right after your film, but the radiologist hasn't read it yet, so it will not include the report. So you have to obtain that later on. Hopefully you have easy access through the portal. Okay. What bothers me is when someone says, well, I had an x-ray and the doctor said it was fine. It was a single image. It may have been a lateral image. It might have been an AP image. But you treat the client, not the x-ray. You can have someone that everything looks fine, and you go test the joint. It's like, wow, that doesn't move. That's stuck in this direction. And then the opposite, it certainly moves. So it's not a fusion. It's still a mobile segment that we typically can treat. Okay. There is a sit to stand radiographic protocol, and that is listed in the handout. You have easy access to that. Okay. And so that's a lateral x-ray, but you can also visualize the coccyx with an AP. What does AP refer to? Anterior, posterior, okay? And there's a specific protocol for any of those imaging. For an AP or for a lateral, there's a specific protocol that must be followed, but sometimes the technician doesn't know that. The radiologist doesn't know that a specific protocol should have been followed, and that can be unfortunate. But you do want to clear your bowels, because if you could have bowel stool and even bowel glass somewhat obscuring the image of the lower sacrum. I'm sorry, yeah, lower sacrum and coccygeal segments. They are thin bones, so the lucency can be challenging on x-ray. So you can optimize that by making sure bowels are clear. And then there's that specific protocol that I just briefly allude to. They angulate the beam downward to capture the lower sacrococcygeal region, okay? So follow the protocol, and other imaging modalities would be ultrasound, an MRI, which can be static or dynamic. They can do an MRI with you sitting and then with you either standing or sitting, leaning backwards, or whatever position they want. You can also visualize it with a CAT scan. You can also do a CAT scan and then run it through a program which is called 3D reformatting. And so they take every sagittal, every transverse, and every frontal image and feed it into a computer and combine them, just like I showed you, just like that. You want to see that again? Just like that. Okay, good. Now you've got it. So then they can create the 3D images. And if you'll think back when we showed you those brown images of the sacrum, that was from a 3D reconstructed images, you can take that CD, okay, and you can feed it into a 3D printer and you can print that person's anatomy that they can hold in their hand and it becomes 3D, that maneuverable, okay? All right. Now, another test would be fluoroscopy. That has rather good imaging power. And naked eye visual observation in a very unusual positioning, like a hyperextended coccyx, that may give you that information. But most of the time, it's too subtle. Excuse me, I've never looked at someone's coccygeal region, sacrococcygeal region, and say, oh, that looks side bent. It's only when you put your thumbs under the sulcus, then you can say, oh, that looks side bent because on the left side, the sulcus is deeper, and that means tip is left, right transverse process is lower, okay? But definitely use visual observation, definitely use it to evaluate the status of their skin. Do they have a cyst, a local source of inflammation in which they're not aware, okay? So you can read up on the precise protocol. And that's basically what it looks like. That's what they're plotting. So see the yellow dot on the top? That's in the middle of the sacral ILA. And then they're going to plot a line. The blue dotted line goes all the way towards the most antero-inferior point of the last segment. And then you strike a line again. See the yellow dot at the top, and then they draw it down to the very same point and measure the angulation, okay? So they're measuring, by comparing them, they're able to see what is the physiological movement in that joint with typical positional changes. And if it's 25 degrees or less, then there is some limitation of mobility. If it's on the lower numbers, okay? More like if there's 5 or 10, 15, that is a reduction of mobility. But if it's in excess of 25 degrees, then that is a increase of mobility, and it's called hypermobile, or if it's a lot, then it would be called unstable, unstable. Okay, so this describes that again. Here is an AP X-ray of the sacrococcygeal joint. Interesting, eh? So that one looks rather symmetrical. I'm not seeing a hint of a lateral deviation. X-rays can be a little fuzzy. CAT scan is the better way to go, or even fluoroscopy. Okay, so that describes that test, and a good resource. It was retrieved from Radiopedia, and I would recommend reading that article, and I certainly would recommend reading the Skalski article, which is mostly a lot of images. Good. So if you're going to have x-rays of your tailbone, you got to be educated in what x-rays you need, because when you go to the local facility and you tell the technician, I need a sit and stand coccygeal x-ray, if they look at you funny and they pause, trust me, they don't know what you're asking for. Dr. Foy in his book spoke a lot about how he had to go and establish rapport with the radiology department in order to gain their cooperation in giving people a proper sit x-ray and a proper stand x-ray of the coccyx, and including the sacrococcygeal junction. Okay, so they should clean their bowels, so there's not much material obscuring the coccyx. And the article that is referenced right here also describes the technique for X-ray, the angle of the beam, the fact that they kind of narrow it down, etc. Collimation is the name. Aha, what are these? These are the 3D images I was referencing. Okay. And you can print those and hold it in your hand. So in the middle, in the first image, it looks rather symmetrical. I don't think that person has a side bent coccyx. In image B, that's certainly a distinct angulation down there. That looks like a 70-degree angle or more. Okay, that's very interesting. And then we come to a posterior view, and it's a little bit easier, I think, to judge, is there a lateral deviation? The first image somehow just seems a little funky. I'm missing precisely why I don't like it, so forgive me, but I like the third one. So in the third image, they're striking a line from near the bottom of the sacrum and taking that through the tip of the coccyx, but unfortunately, it looks a little bit off. I think that the last image, the lower line they struck, is actually hitting the bottom and outer aspect of the last coccygeal segment. I guess what I would say is in terms of marking, make sure you're consistent. That's the most important thing, okay? And looking at image C, it looks like the sacrum is already tilted a little bit because you have this subtle left deviated line, okay? And I think that if you were to strike a line from the sacrococcygeal cartilage and then draw it down either to the outside tip of the coccyx or the middle, and to do the same thing for any future imaging, that should be, you should have some replication of your technique with different practitioners, okay? In other words, just stay on the same protocol. Especially for a research study, you don't want one of the clients being imaged with a line drawn to the outside of the tip, and then another person drew it to the middle of the tip. So anyway, Skalski is great. You want to find that article, and it's free download. Gorgeous images. I did not include all images in this presentation. It's a team approach. This is what I recommend for the team: a competent manual physical therapist, and I'm referencing orthopedic manual physical therapy. Okay, you're able to work with joints and all their attendant tissues. And the definition of a joint was changed quite some time ago, and it was to include all structures that attach to the bony structures, include the ligaments, include the capsule, include the innervation, yada, muscle, yada. Okay, so joint is much more than just the articular connection, okay? I would refer to that as the articular surfaces, but when I call it a sacrococcygeal joint, there is a larger anatomy that comprises that definition, okay? Let me take a sip of water, bear with me. Okay, so on our team, we want a competent manual therapist. We want a pelvic floor physical therapist for internal soft tissue work, motor control, etc. I like having also a skilled soft tissue clinician because their external skill set working on muscle exteriorly, okay? Only a few of them venture internally. is much greater than my own. They are going to spend a lot more time with this client working on the regional soft tissues. Okay, that they do it day in and day out. They do a better job than I do. Okay, so a good soft tissue clinician needs to be on your team that you refer to. You need to have a good relationship with an interventional pain management physician. They're typically an anesthesiologist, but sometimes it's a doctor of physical medicine and rehabilitation. You need to build a rapport with them and get them on your team. They can also do some imaging if needed. They're a very good resource for imaging, all right? And the radiologist should be familiar with the main protocol, which was published. The first one was published in 1996. And almost anything that says sit, stand, x-ray makes reference to his work, okay? When Dr. Foy set up his practice in treating coccyx pain, several times he went over to the radiology department to make sure that he developed rapport with the department and with the actual radiologist and the technician. And it took him a while to get them to agree to accept the sit to stand x-ray protocol. Okay. Now, on your treatment team, the treatments, you would also want to have a general or an orthopedic surgeon who is skilled with coccygectomy. Not all of them do that. Okay, you need to find out who in your community does it and does it well. All right, so number 7 is mental health clinician, and it gives me great pause. So our clients might need support. They might need another perspective from their own. So I think counseling is a good idea if someone has a severe pain, a chronic pain condition, if you can get their cooperation. Surgeons may be helpful in the diagnostic workup, and they have a deep understanding of proximal structures. So occasionally you'll need to have available a gynecologist, a urologist. There's also a practice called urogynecology, and you also want to have access to a general surgeon, an orthopedic surgeon. Okay. And a little bit redundant, but I find skilled soft tissue clinicians to be very helpful for reducing whole body nociception. Okay, so what are typical treatments? You want a balance between rest and activity. Remember the old days when they said bed rest for 2 weeks? Nope. Now it's bed rest for a few hours, but then get up and walk around. Minimize sitting. You know, instead of dinner and a date, no, I mean dinner and a movie. So instead of dinner and a movie, if sitting tolerance is limited, then, you know, they may have to change things to just doing one or the other. A coccyx cushion with a cutout can be very helpful. I like one that is a lateral wedge. I actually designed that in 1981 and sold some very nicely upholstered one in Albuquerque. Connected with a soft tissue guy, but then he moved back home to Minnesota. Made a little bit of money, but I decided this is not my gig. I'm a clinician, so I, didn't worry about it. And in short order, sometime later, we started to see the wedges on the market. You can still find them for about $13. And they are perfectly fine. Okay, ice or heat. We buy a very small round or rectangular gel pack. It's blue, and you can put it in the microwave. It's stamped with my contact information, and we give them to our clients. And you can also microwave it if you want heat. And they can fold it in half and just kind of tuck it under that lateral sulcus area. Get as much contact as you can. I am a fan of topical creams. We have good data that the Capation, I hope I'm pronouncing it correctly, Capation cream is very effective. So topical application, yep. And then I have another favorite, which is called Coralite. And it contains the highest amount of camphor and menthol as other types of pain creams. Okay. The others typically contain between 4 and 5% only, period. I do teach my clients when you apply any gel that brings heat, the camphor or menthol or the other one that I had just mentioned. I'm tired from the game. Sorry about that. So what happens if you start burning after you put the pain cream on? Okay. Water won't take it off. You'll need alcohol. Okay. Over-the-counter medications may be helpful. For those with absolute severe pain, I advocate appropriate medication. And sometimes I send a letter making a plea for consideration for a stronger medication. Exercise, pelvic floor treatment, and that Coralite that contains 11% camphor, 11% menthol, you can get it at the dollar store for less than $2. It's a little like a Carmex, C-A-R-M-E-X container. You can also benefit from external massage. There's some articles on shockwave therapy, ultrasound diathermy, any physical modalities, prolotherapy and PRP. There's just a little bit of that information. Actually, most data is more of a sales pitch rather than a published article. I did find one, it's in the reference on the use of prolotherapy. And then manual manipulation may be helpful. Sorry, let me back up. Okay. There is a technique for evaluating and treating the coccyx to see if it's deviated laterally or side bent. And the evaluation is done in treatment. The evaluation is done in sitting, and the treatment is done in sitting, and they use a muscle energy technique. I find it so difficult. I cannot screen somebody's tailbone for a lateral deviation in sitting. Okay. So I have my clients are prone, and I find that so much easier when looking for side bent, screening for a rotated one, screening for a hyperextended or hyperflexed. The last one requires a glove technique described later on. Pelvic and hip, SIJ posture and micromotion restrictions should be treated. They also are just beginning to do some cementing of the intersegmental joints. And I read one of them that had good benefit. There's one article at least on excising the tip of a little spicule at the very last coccygeal segment. And I really struggle with that. I think that I have a hard time understanding how that would cause pain. Please share your thoughts if you feel otherwise, okay? Tincture of thyme can be helpful. TENS or other electrotherapy devices can be helpful. And when I have someone apply their TENS, let's imagine that my sacrococcygeal pain is on the left side of my body. And let's suggest that it persists after we restored normal symmetry, normal mobility of the joint. So some people would say to apply the electric pads directly on the site of pain. And I think, if it's already really facilitated, the brain's already too aware of that area. What if we put that patch on the opposite side of the body? And I truly think that could be very helpful. I also suggest to some of my folks which have a hard time reducing their pain, as we all do, a small population, I recommend they put the electrode to encompass above and below the TMJ, and the joint of the TMJ is right in front of the opening of the ear, or at least very close to that. Okay, if you put a TENS patch there, think of all the real estate that you're capturing. You're capturing all of the branches of facial nerve, and except maybe retro auricular, but you're basically capturing all of the facial nerves and all of the branches of the cranial nerve 5. Okay. And so that can be very, very effective. Your brain then paying more attention and paying less attention to the injury on the opposite side of the body. Assurance, people need information, I spend a fair amount of time, helping them understand how to access good health care. And to help them understand their injury doesn't mean that every time they pick something up, they're prone to injury, yada, yada. Assurance, tell them about tincture of time, let them know, well, a large percentage of people 6 weeks later are so much better. So I certainly think that you will be as well. Yeah, pain neuroscience education is helpful, but we need to respect that coccydynia is a sensation. It's not a perception, it's a sensation, and you need to treat the local nociception. There might be a few outliers that you can treat it distally, or you can treat it with anything that reduces stress. But I suggest we all tread cautiously and with respect, and not give the patient cause to think that we think their pain is in their head. Counseling might be helpful. Laser might be, I think there's at least one study on using laser. And then there's a Hesch tool for assisted mobilization. So this would be, the tool would be for someone who is just a bit jittery about being touched. So then you show them this tool and you say, so I'm going to touch you with this soft tip of the tool, and I'm going to put a little bit of force on you. Can I push on your hand? Okay, so this is the amount of force that I'm going to be applying there, but I'll be holding it for 2 minutes, or I'll be giving it little oscillations. Just describe the procedure, show it to them, and reduce their anxiety. Okay, some benefit from a partial coccygectomy, but some do poorly when it's only a partial. So a complete coccygectomy has greater support in the literature. All right, so injection and radiofrequency ablation can be another alternative. Spinal cord stimulator, and there was one successful case. Tension sutures to tighten things up. There was only one case report on that, and it was effective. Alternate care, such as Reiki, etc. How on earth is that helpful? Someone's putting their hand above my body and they're visualizing Chinese symbols. How does that, help me with my pain? I'll take that treatment anytime, because I actually feel the heat. I feel the warmth of their hand. It's a different sensory appreciation than just light touch or deep touch or firm or soft pressure. It's a very different awareness. And I find it profoundly relaxing. And I feel that deep relaxation really can facilitate healing. All right. I have a very nice bone and joint meditation. And the general concept of that is on YouTube. Just type in my last name, Hesch meditation. And it's very simple and straightforward. I'll defer that to you. Other treatments could be any other alternative care, but I always tell them, making an experiment. If after 3 visits you feel like it's not helpful, then I would stop. But always have an alternative available if they have constraints on their finances. Sometimes simple is very effective, okay? You need to pay attention to the sitting environment, getting a sit-to-stand desk, getting a very good ergonomic chair with the mesh that can breathe. And sometimes you have to have them purchase a taller gas cylinder so that they can sit taller with hips equal to or just a little bit higher than the knees. If hips are going to be below knees, it shouldn't be 10 or 15 degrees. It should be less than that, okay? So there is a systematic review of treatments. And they looked at 64 studies and then pared it down to 45 of them. And the greatest improvement of pain was with what? Radio frequency ablation. Amazing, eh? Radio frequency treatment. They definitely improved. Also, extracorporeal shockwave therapy was helpful. Then coccygectomy, then injection. And a very small portion received benefit from a ganglion impar block. And then some responded to stretching and manipulation and conservative usual care. All right, very good study. So, are there any contraindications to treatment? Absolutely. Okay, this list should not be perceived as complete. We must always be vigilant and trust our wisdom and intuition. Okay. Undiagnosed blood in the stool, that needs a medical workup. Current or recent pilonidal cysts may require screening, may require referral. There is at times a lack of appropriate imaging. So the client might say, well, I had a terrible motorcycle wreck and I landed on my bum and I really hurt my tailbone. But they did x-rays. I got the ER within less than an hour. I was in there and they shot x-rays right away. But it showed things were normal. So we wait 6 weeks and their coccyx pain becomes worse. What happens? Well, after the initial trauma, the inflammatory response is in process and they get swelling in the joints. So the swelling acts as a buffer and a stabilizer, okay? And then as time goes on and they recover, that swelling gets reabsorbed and now it's less stable. And now the dislocated segment can actually perhaps move further than before, okay? We know that's true with the pubic joint. There are 2 or more studies on x-raying it after trauma, and the x-ray looks within normal limits. And then the person loads the pelvis and does a spring test laterally through the ilium, and they shoot an x-ray, and all of a sudden, the interpubic width, which initially was increased somewhat, then increases greatly. And if it is more than 5 centimeters, it's most likely going to get surgical fixation. You can check the literature on that, okay? So sometimes they don't do a repeat imaging, like what image do you have? Well, I have the x-ray from the motorcycle wreck, 9 months ago. I'm like, oh, well, did they do a repeat x-ray? No. Sometimes you need a repeat x-ray. All right, a recent infection, that should raise a suspicion, and I would refer back to the doctor for blood work. Let's see. These are contraindications. Lack of written consent, absolutely. We have a very nice consent form. You can read up on it and you can use it. Lack of rapport, that's my worst failure. If the patient doesn't have a strong degree of confidence in you, I would not proceed. But once in a while, I'm tired, patient gets the best of me, and I proceed when I shouldn't. So I urge caution. Lack of presence of an adult, okay? So if you have an underage patient, they need to have adult supervision during the treatment. And other question mark. There's probably always other. All right, so we can talk about manual treatment now. And I want you to see the consent form that is in my handout. And you are certainly free to use that. There's an abstract right before that that I would like you to review. And I'd like you to read word for word the permission, the consent form. And then following that, I have several paragraphs. It's on page 34 of the handout on soft tissue treatment, which has very, very good results for a fair amount of people. Okay, so please do look through the handout on the soft tissue studies and theory. So now we're talking about positional and mobility dysfunctions. And when I name these, I mean that they are treatable. You know, someone could have developmental asymmetry, but they would most likely have normal mobility on each side if there was no fusion. We treat the person based on testing. We don't treat an X-ray image. All right. So read through the text there and let's move on. So not every mechanical dysfunction of the coccyx is amenable to manual therapy. Okay. Now, most coccygeal injuries do heal over time. That's called tincture of time. However, a traumatic injury such as causing a hyperflexed coccyx might induce instability due to ligamentous injury. And the literature supports my experience that the people with coccyx injuries that have absolutely severe pain are least likely to respond to manual treatment. Most of those folks do end up getting a successful excision of the entire coccyx. Lesser sprains will respond to manual care. The intercoccygeal segments, if there's dislocation or a luxation or a slight slippage, I don't find that those respond well to manual care. And it might be the fact that it's challenging to go inside the rectum and actually isolate each individual coccygeal segment. I invite you to try and see what you learn. So I'm going to cover patterns that do respond well. And then one of the very last patterns I'll discuss is hyperflexed coccyx. Okay, so let's talk a little bit about general mobilization. James Manel, who is father of John Manel, in 1952 put out a book, and he described more directions of mobilizing the coccyx than I've read in any other works. And he talks about an internal mobilization that uses distraction, repeated a few times, and then a glide in one direction, a glide in the opposite direction. Okay. So an anterior glide, posterior glide, left glide, right glide, left twist, right twist. And those should be done with distraction. What am I missing? I didn't say side bending, add side bending as well. Okay. So he describes doing all of those. Some people respond better because the coccyx is so deeply curved that they will respond rather than to a rectal approach, but females may respond better to an anterior approach. I defer those clients to pelvic floor therapists for cultural reasons. And also after I do mobilization, and it is stable, and they are less symptomatic, and it is continuing to heal. It doesn't require repeat treatment. I do go on to refer them. I recommend. I say, well, maybe 3 visits of pelvic floor work could help you at this stage, now that the structure is balanced. And so even though you've had it already, going back might make sense. All right. What are the patterns that we're going to go over here? They are side bent coccyx, also called laterally deviated, rotated coccyx, bilateral I'm sorry, forgive that term, bilateral anterior ilium. That is a mistake. Just draw a line through that one, please. The next pattern is left lower windswept pelvis. That's a pattern I stumbled on in the early 90s, and that correlates well with a rotated and side bent coccyx. And then I'll discuss hyperflex coccyx and hyperextended coccyx, I think in the reverse order. My apology, I just can't get this perfect. Just doesn't work. Okay. All right. So you could say the coccyx is side bent right. Okay. And a lot of people would look at the x-ray or look at the image and say, but the tip is going left. Isn't that left side bent? No, it's not. It's right side bent. Why? Well, in manual therapy and biomechanics, it's named for what the top segment is doing. So even though the tip points left, it doesn't matter. At the top, that coccygeal segment with its transverse process, if it's side bent right, you can see that the right transverse process dropped lower when the tip went left. So it can be a little bit mouthful to give kind of a full explanation in the nomenclature, but I find it very helpful. It tells the person and any other clinicians exactly what we're trying to achieve. So I would name the most common pattern side bent coccyx tip pointed to the left, lacking left to right spring mobility. It implies that they do have right to left mobility, okay? And that is much more lucid than saying the person has a right side bent tailbone. There's a lot of people out there who wouldn't know what it would mean, and they'd look at the picture and say, but isn't that left? So this one gives a more lucid visualization. Let's talk about this. When I see people with side bent tailbone, some of them may have seen another practitioner and have been given the same diagnosis, but the care was not as effective. And I asked them, well, how long did they work on trying to straighten it out? And they say 30 seconds. What I use 3 minutes of pushing on the tailbone for a side bent pattern, another 3 minutes pulling through the ligaments on the right side for a left side bent tailbone. Okay, all right. There's very limited data on a side bent coccyx, okay? But guess what? It was actually described first in 1935 in a journal called the Physiotherapy Review, and it was also described again by 2 other authors in 1938, okay? So the profession's awareness of it was present at one point of time, and I worked so hard to find that article. I kept asking everybody, where is the original source? Well, I don't know, everybody knows about it, or something like that. I've been on some wild goose chases, and no one knows where the original source is. And somehow, I think I went to coccyx.org, and you should certainly visit them, and that's listed later on. And I think I went to their literature resources, and I went on down. And so I started to read some of the very, very earlier literature. And I was like, oh my gosh, it was mentioned in 1938. Okay, it has also been reported in a 3D CAT scan study by Lee et al. In 2016, also in an MRI study, and both of those are listed in the references, in which 30% of a symptomatic population did have a side bent tailbone. Now, when someone presents this way, the side bending component, the tip moving off to the left, is the primary pattern, and a secondary pattern is a rotation to the left. So the front of the coccyx twists on a vertical axis, okay, and it twists to the left, okay? So that is then named left rotation, okay? And I have not encountered literature describing this rotated coccyx. I stumbled upon it rather recently and was quite astonished. I thought that correcting the side bending would take care of any rotation, and I found that that's just not always true, okay? But sometimes the rotation corrects when you make a correction to the side bent pattern. All right, this is still side bent coccyx. So client is prone, and you would find local tenderness, especially at the tip of the tailbone, more tenderness on the left soft tissues, but some on the right as well. Actually flip that, reverse that. It can be variable. You'll certainly have a tight sacrospinous ligament on the right, and that can be tender. Just depends on the unique biomechanics of that person and what the pattern is. So you will have, I'll say, local tenderness. You certainly will have a deeper sulcus on the left side when you palpate, and there's a graphic coming up to show that when there is a side bent coccyx with tail pointing left, all right? And when that's present, you're gonna have a very tight right sacrospinous ligament. We'll teach you how to palpate and spring that ligament. And you know, the spring would be limited, it would be hypomobile on the right side with this pattern, okay? A right to left spring mobility would be present when you contact the lateral part of the coccyx. I tend to put it with a thumb, and then I stack a thumb, and then I push till it stops moving, having taken up the slack, and then I impart that little 3 pound. 3 pounds to take up the slack, 3 pounds to thrust is average. What's the correct amount of force? The least amount of force that gives you good information, okay? So the 3 is just a guideline. And then so again, if you're on the right side of the coccyx, you can spring it to the left. Even if tip points left, you can actually make it go further into the pattern. But when you try and do the opposite, and I'm sorry, I have a typo here. It says blocked right to left, and that should read blocked left to right spring mobility. So let me take a quick note. It should be blocked left to right and not right to left. I apologize for that. It just seems impossible for me to do something without some boo-boos I overlook. All right. So we have some nice video on evaluating lateral deviated coccyx. And so there are live links in your digital handout. Okay, please review them. And they're not too long. So this shows, again, the palpation of the sulcus. So that you want to first palpate the tip of the coccyx. I just put my hand down on the sacrum, fingers pointing towards the toes, and I fold my middle finger so I know when I'm on the tip of the tailbone, and then I just move my fingers to each side and pull up. Okay, you should go up about 3/4 of an inch, and your fingers should be at least 3/4 of an inch apart. okay? If you go too far, you'll bypass the transverse processes, and all you're doing is getting under the ILA of the sacrum. Here we want to evaluate the sulcus that is under the transverse processes. So I'll let you reread that later on. Commit it to memory. How do you find a sacrospinous ligament? It's a deep ligament. If we were to reflect this superficial ligament here, just take it off the body, you would see a lateral ligament there, which connects to lower sacrum, but also connects to the coccyx. Okay. Well, if this coccyx were pointed to the left, this lateral ligament would be very tight. Okay. So how do you find it? We describe it in the video as well, but you find the tip of the tailbone, and then you bring your index fingers on both sides of the tip of the coccyx and then move up, okay, to the sulcus, and then move about a ½ inch higher up, and you should then be at the sacrococcygeal junction, or even at the lower part of the sacrum, close to the ILAs, and then you just move laterally, and that sacrospinous ligament is deep to the sacrotuberous, okay? And then to test the spring mobility, you would load both of those ligaments and then spring it, okay? But your most important landmark is going to be under the sacral ILA and then lateral to it. And you can drop down a little bit. Just go laterally from that. Load the tissue and spring it. If there's a lateral coccyx, it'll be hypertonic on the right sacrospinous ligament and a little bit of the sacrotuberous ligament as well. I'll let you read on that. All right, I want to talk about mobility testing of the coccyx. So you're going to push on a bone to a stop point, because we're talking about tip pointing to the left. We're going to want to test each side of the sacrum, okay? So we use contact on the outside of the coccyx, capturing multiple segments, and you load it and spring, trying to find out if the coccyx can spring to the left side and if it can spring to the right side, okay? You always test both sides, all right? So here's what you do. You push on a bone. Let's suppose I'm pushing on the right side of a person's coccyx and it was side bent left. Then I would be able to push on that bone and push it to a stop point. I would keep my force there. It's probably about 3 pounds. And then I would thrust it with an additional 3 pounds of force. Okay. But I don't thrust and let go. Okay. I would thrust it, but let the bone push back. I would feel the recoil of the bone. That's so critical. It is so clarifying when you do it that way. I know the tradition teaches it to load and thrust and grade that excursion. You're going to find you really like when it recoils and you feel the quality of that excursion, okay? All right. Now, you then grade the movement, and that's easy, okay? Because I use a very simple scale for measuring mobility, okay? The tradition of manual therapy has so many scales, at least 13. This is like, oh my gosh. And let me rephrase that. A large number of ways of grading mobility and a large number of different grades of mobilization. And for me, I can't do the subtle grades, but when motion is blocked, when you unblock that, that's where you get the biggest bang for your buck. You might test other directions of motion and say, well, that's a little hypomobile. It moves, but it's kind of stiff or something. Well, I don't spend a lot of time there because time is money, and I want to get the biggest bang for my buck. So I keep testing to find where motion restriction is the greatest, where mobility is blocked, because when I free that up, we get the greatest benefit, okay? And if you can't free it up with normal technique with 2 different attempts, it's probably developmental anatomical anomaly, or it's fused. Okay. So anyway, let's talk about grading. So we do the spring test. All right. You can certainly repeat it a few times. Slow is best. You want to slow it down and pay attention to what you're feeling. So let's suppose we do a spring test. Number one, I could say it's normal. That means I can load it. I spring it with a reasonable amount of force. It thrusts forward and it bounces back with integrity. That's a normal joint. Okay. Okay. The next type could be blocked. Okay. And I sometimes use the terminology in my writing, hypomobile, but in my writings, I'm referring to blocked mobility. I'm trying to segue into saying blocked more often, but it's a process. All right. And what is hypermobile? So hypermobile would be a definite limitation of how it recoils. So you might load it, but you'll find it may take longer to load and take up the slack. And then you thrust it, but it might feel like it could go further instead of the thrust taking it to an end range. And after the thrust, when you allow it to recoil back into your hand, it's going to recoil with less enthusiasm than a normal joint. Okay. Sometimes it's the recoil that is informative. So next page, we already talked about that last paragraph. All right. So I would like you to practice on a bathroom scale or practice on a postal scale. And I want you to find out what is it to push with my thumb 3 pounds. Okay. Now, once you load it to 3 pounds, I want you to stay there a little while. And then I want you to thrust it again up to 6 pounds and then let it bounce back into your thumb. Okay. Don't let go of it. Okay. You want to load it, spring it with 3 pounds and allow it to recoil backwards. Okay. Very good. When you practice that on 10 individuals, you're going to have a distinct appreciation for that test. Okay. When you have different body types, you'll start to collect a data bank. And it's like, gain an appreciation of the amount of excursion, the amount of force you'll develop finesse in how much force you apply based on experience. So you got to go out and treat 10 people, 10 normals. So you know what normal mobility is, and then you need to treat 10 that have a deviation or some other dysfunction. Okay. So, sorry, a little deviation there, like the Coccyx. But remember, it's 3 pounds of force to load and then an additional 3 pounds to do the spring test, okay? So how can you practice if you're on vacation or something? Buy an orange, okay? Take the orange, load it. So you just indent it, with 3 pounds. And then after that, I want you to thrust it with an additional 3 pounds, okay? And let it bounce back into you and then lift your thumb off and you'll look, there's no dimple, okay? But if you load it and thrust it and let go immediately, then it's going to recoil more slowly and you'll see the sulcus, okay? You want to do it the first method. Remember, load to where motion is stopped, forward spring, and allow it to spring back into your thumb or hand. All right, very good. So I suggest that people count 1 second, and the way to count 1 second is to go 1001. Okay, so you take up the slack, and I recommend you do it a little bit slowly. So pushing it 1001. Okay, and then you hold it there, and now I'm going to thrust it 1001 and allow it to recoil into my thumb. Okay. So now you know how to perform a proper load, spring, and recoil test. You can do that on any part of the body. You can do cartilage. You can do somebody's nose. You can do the fibrocartilage. Can I load it? Can I spring it to the left? Does it bounce back? Yes, it does. Can I do the same thing the other direction? Yes. Okay, very good. So as you practice that on different joints, it'll become second nature for you. But please carefully read the directions, commit it to normal, to commit it to memory. Okay. So later on, you'll be applying more force. If you were to spring a knee joint, then you would use more force. Later on, we show you a lower pelvic mobility and postural pattern, and you need to use a little bit more force, 10 pounds when pushing on an ischium. Okay. All right. So here's a left to right coccyx spring test. Load it with about 3 pounds of force, and then spring it and allow my thumbs to feel the bounce back, the recoil. So if someone had a left deviated coccyx, this would be blocked. Okay. Now, treatment for a coccyx in which the tip points left and you can't spring left to right would be to contact it laterally with one thumb, stack your other thumb on it, and impart 3 pounds of force, sustain it for 3 minutes. And after that, you would then reassess things. If it then springs, you would retest sulcus and tone of the ligament. All right, so this slide is just slightly out of order. This one should have preceded the treatment slide, and I apologize. This is how you would do a spring test on the right side, springing to the left, okay? And you would test both directions before treatment. Okay, so this is describing the mobilization, which I just did. And the good news is home program is not needed. It typically resolves with one treatment. So I call it once and done. Okay, and then the second part of the treatment, I capture the ligaments on the right side of the coccyx and lower sacrum, and I engage them, pushing them laterally and a little bit downward. Okay, so I just load the ligaments and then I stay there. So very small amount of force, 3 minutes. Nervous system likes it. The less force you use, the more likely the nervous system is gonna cooperate and allow the treatment to happen. Okay, let's see. Yeah, that describes what we just showed with the capturing the ligaments. And after that, when you've restored normal lateral mobility of the coccyx, we've taken care of the side bent or lateral deviated element of the coccyx. And now we need to find out, well, you know, is it rotated or is it not? I only started doing this rather recently. Have not encountered much in the literature at all, other than James Monell, 1952. So you want to do a spring test, a PA spring test on each side of the first coccygeal segment. And there's some nice video that shows you. There's video on the rotated coccyx. And here is palpation for left rotation screening. And I put a battery button on top just to elevate my thumb a little bit, you know, to help it look like it's rotated. Okay. So if it's rotated, the left side of the C1 coccygeal segment will be more posterior. And when you try and spring it forward on the left, it will be stuck. Okay. Treatment is so easy. Okay. You just stack your thumbs. Okay. And you just lean into it with about 3 pounds of force. And if the mobility is blocked, in order to treat it, you just maintain that force. So here's another video on side bend and rotated coccyx evaluation and treatment. So the top one is for side bent and the bottom one is for rotated. And then treatment is so simple. All you do is lean into it. You just stack your thumbs, push it forward with about 3 pounds of force, and then hang out for about 3 minutes and then retest it. Okay. Again, no home program because it once and done and it's corrected. The body likes correction. Frank Lowen told me that in late 80s, and it's absolutely true. If done correctly, the body likes to embrace and maintain the correction. Okay, so now we leave that alone and we come to a lower pelvic pattern called left lower windswept pelvis. And the pattern consists of the following and is missed with traditional pelvic palpation because they're looking at the top of the pelvis. They might look under the ILAs for verticality, but that's all they do. In this one, we add more palpation. All right. Number one, in the sagittal plane, the left pubic bone is more posterior. So if you're palpating the face of the pubic bones, there's an upper third, there's a middle third, and there's a lower third. When you get to the lower one, on the patient's left, my thumb goes deeper, okay? Correlates beautifully with blocked PA spring to the ischium. So when we get them prone, we note the ischium is prominent towards the ceiling, and we notice we can't take up the slack and we can't spring it, okay? So then we will test mobility of each ischium. And if it's blocked in one direction, honestly, it'll be blocked in the other direction. I've never found an ischium with the lateral deviation that was blocked in only one direction. Typically, both of the ischia are blocked with respect to medial and lateral spring mobility. Okay. Palpation, the left ischium will be further away from midline of the body, the midline gluteal crease, and the right ischium will be closer to the midline gluteal crease. And they will lack mobility in all directions. Okay. So there will be a subtle difference with respect to mobility of the hip in abduction and internal rotation on the left hip and the opposite on the right hip. And there's a subtle reduction. The hip abductor can be restricted, and internal rotators will test differently. Okay. And the lateral ischium pattern, lower left windswept pelvis, correlates with the left side bent and left rotated coccyx. Okay, not always. So you can have the left lower windswept pelvis sometimes with the pubic joint rotation. Sometimes the pubic joint is fine. Sometimes the lower windswept pelvis pattern will also present with a lateral deviation of the coccyx, tip pointing left. Excuse me. And it will also present with a rotated coccyx, and other times it's not present. So you only treat what you find, okay? Yes, so I think that this left lower windswept pattern is more of a global pattern that involves every joint of the pelvis. So I think it involves the entire pelvis shifting over, and I can do that in standing. That's my pelvis moving on my hips. That is my pelvis moving in relationship and with the trunk. Okay. It's also movement happening in my hip joints, and I believe a little bit of mobility happening in the SI joint. and the pubic joint as well. We need studies on it. There are no studies on it. That pattern correlates with a pudendal neuralgia because there is increased tone in the sacrospinous and sacrotuberous ligaments, and that very sensitive nerve traverses between those ligaments on its trajectory. And I have one video case on YouTube. It's under Hesch pudendal neuralgia, and you'll find I treat a young lady who had a lateral windswept pelvis, and she responded extremely well to treatment. She had had prior pelvic therapy that wasn't successful for her pudendal neuralgia. I first discovered that pattern in 1990. And so you can see that in this slide, I refer it to 1990. But I've revised that book so many times. I also have it listed as 2023. And it's undergone many revisions. That's what we do. Okay, so beginning the eval, you're going to look at the person in supine. You've already gotten the signed consent. You've demonstrated with the pelvis what you're going to do. You've gotten their buy-in. They don't display any hesitation. And you palpate the upper third of the pubic bones. Make sure you're on a bony element. You don't want to be really lateral with a wide space, because you're going to fall over into the soft tissue of the obturator foramina. Okay, so your thumb should be the pubic width. A typical pubic width is 2 to 4 millimeters. So if you have at least a quarter of an inch between your hands, maybe a little bit more, that's fine. Okay, so you palpate upper third, middle third, and here I'm palpating lower third, and you can see that my thumb is deeper on the lower third. Okay, it also correlates beautifully with a prominence of the ischium when the client is prone, and it correlates 100% with blocked PA spring of the ischium when the client is prone. Give me one moment to take a quick note. Okay, thank you. All right, so here you see that I have the palm of my hand on the lower third of her buttock. And if you look at the bony anatomy, that's a rather flat portion of the ischium, which is quite surprising because we're all thinking of the ischial tuberosity that's very curved, and many, many, many parts of the pelvis are curved. Here's one flat area, okay, of which there's at least one other one, a couple others. All right. So this is the PA spring test to the ischium, which actually tests mobility at the pubic joint. Okay, and so you place the heel of your hand there, and you load the structure, and then you spring it. Okay, and it will be blocked if they have the first component of this pattern. If the spring mobility is normal, then you don't treat the pube. You then palpate the medial aspect of the ischial tuberosities, and I apologize, I've got to run downstairs and get this plugged in, so give me 30 seconds, please. Okay, we're plugged in. We're going to have some battery power and not run out of it. And let me just close that curtain, and then we'll get right back on track. And we are getting pretty close to wrapping it up. We're probably in the final 20% 15 or 20% of this presentation. All right, so you will palpate the medial aspect of the ischial tuberosities and compare that to the midline of the gluteal crease, okay? Sometimes their clothing doesn't match the crease, so not the crease of the clothing, the crease of the buttock. And you'll see in this image clearly the ischial tuberosities are shifted over to the left, okay? It might be normal anatomy. Some people develop pelvises that are asymmetrical. That's why we do mobility testing. We don't treat position, we treat mobility dysfunction. So the next thing we do, can I spring an ischium? Doesn't matter which one you choose, doesn't matter which side, because it will be blocked in every direction on both sides if it is a true treatable left lower windswept pelvis. Okay? And we only use about 10 pounds of force to take up the slack on an ischium, and then 10 pounds to do the actual spring. The true amount of force is actually based on the individual on the table. So it's the least amount of force in which motion stops and gives you accurate information. And then you use approximately that same force to do the spring. All right. So if it's blocked, we're then going to go forward and do treatment, okay? We, of course, would have screened for a side bent tailbone earlier, and we now treat it. We now treat the lower windswept pattern, okay? If the pubic joint was rotated, then we proceed with this treatment. That's a 2-inch diameter dowel with foam, with pipe foam, and it's taped up so it'll last a long time. I now use a 2x4x8 half round foam, but you could roll up a towel that's the dimensions of 2 inches by at least 4 inches, and you place it under the flat part of the ischium. Person is lying supine, and because the pube is such a thick, dense, strong structure, it takes 5 minutes to move a pube. Only in extremes is it real easy to move, such as postpartum phase or so on. All right, so how then do we treat the next part of it? There is no home program for the pubic rotation because it's once and done, it doesn't come back. All right, so you can see the person is supine now. My goal is to stretch the hip and the ischium medially on the left side. And so I cross the right leg over, foot flat on the table, left knee and hip is bent. I'm sorry, right knee and hip is bent, and the left hip and knee are straight in neutral, and I stretch the left hip to the right. I do it very gently for about 2 minutes. And the homework I give them is to go ahead and do the same stretch for 3 minutes for about 3 days in a row, just to normalize soft tissue length. This pattern does not come back. And then we want to stretch the adductors. I don't control the amount of rotation. Her body's going to find her own neutral with respect to hip rotation, so I don't try to restrict that at all. And I stretch the right hip into extension very gently, but I also apply a little bit of traction, and they tend to tolerate that better. Don't worry about getting all the way to end range. Don't worry about pushing right against a movement barrier. You know, the nervous system knows what you're trying to do with it. It responds beautifully. There's no need to kind of get into the danger zone. Just go to gentle end feel, resistance point, and just stay there. And it actually is more effective that way. All right. So we do this treatment for 2 minutes. And then for a home program, again, we have them do it 3 days in a row and do it for 3 minutes. And that's all they need to do. Okay. Then we want to treat the transverse plane rotational element. So the right hip, we're going to treat in prone. Knees are bent 90 degrees, and we're taking the hip into internal rotation on the right. Stretch it very gently for 2 minutes. Home program is the same as the prior. Then we're going to take the left hip and we're going to take it into external rotation. Same drill, 2 minutes, and then home program. And some people have so much flexibility that it's hard to stretch it. It actually bumps up against the other leg. So for those folks, you can put a pillow underneath the left thigh. And so it'll take that thigh into a little bit of extension. And then when the lower leg crosses over, it doesn't bump into the right leg. Okay. Same drill, do it for 2 minutes and home program 3 days in a row. All right. Home exercise program. We want them to stretch their left hip into a deduction. Okay. They're in side line, right knee is bent for comfort. It's flexed for comfort. The body is in a straight line from shoulders to hip, but the knee falls slightly behind it. You want the hip in a little bit of extension to whatever degree in which it's comfortable, and yet they perceive a stretch. And the lower leg can hang off the table. You can modify how far up or down the patient is, the client. It needs to be comfortable. Okay. And that one you do for 2 minutes. Yeah, this is a home program. You do it for 3 minutes, 3 days in a row, and that should suffice. Good. And then we want to stretch the right adductor group. Okay. So this is a technique that I like. This past week or two, I had someone, and that was simply uncomfortable. And I encouraged just the slightest amount of stretch sensation. But we decided then to just have them lie on the floor and just have them do active repeated abduction on the right side, and do 30 reps, and that really should have the same result. Okay. And then the other home program, they're on their stomach, right knee is bent 90 degrees, and the foot just falls out passively for 3 minutes. And we ask them to do that 3 days in a row. Okay. And you can see the little doggy Lola on the bottom left, and that's optional. Okay. And then this is the last hip stretch. Person's prone, left knee is bent, and the hip is being stretched into external rotation by virtue of the fact that it's stretching the internal rotators by going into external rotation. So little semantic challenge. You know what the intent is. Okay. Now, if the person is real flexible, okay, and the left lower leg bumps into the right lower leg, then if you extend, you put the hip in a little bit of extension by putting a pillow underneath it, then you can do that stretch more effectively. I realize the image is a little bit suboptimal because I wouldn't have it in abduction. You can see it looks like the hip is in about 15 degrees of abduction. I would keep it in neutral, but sometimes we make little boo-boos in Jerry land. So welcome to my world. Good. So that's the home program. Okay. Now, in the treatment, after correcting all of the pattern, we would have then evaluated the coccyx to see if it is still present. We would repeat the spring test early on, right? But there is no home program for a rotated or laterally deviated side bent coccyx. Anyway, that's that. So now we move on to the next pattern. Hyperextended coccyx. Oh my gosh, I have a most dramatic demonstration. This was a young nurse who had pain for several years. And she presented with a hyperextended coccyx. I don't see this pattern, but I think they're somewhat common in the, postpartum population. And maybe it self-corrects shortly after after delivery, but I can easily imagine a large baby pushing the tailbone posteriorly, and the tailbone does go posterior to increase the outlet. So it's easy to visualize how this could happen, all right? This is the one coccyx pattern that you might actually be able to see. My, that looks extended, but the other ones you can't really look at it and say, oh, I think it's lateral, I think it's hyperflex. Nope, doesn't work. Okay. This is a proposed mechanism of how hyperextended coccyx develops, and that's explained in the next slide. I'll let you read it. I don't give it a lot of value, but it's just a theoretical construct. Okay, and here is the video of that case study I was speaking of, and so you do want to watch these videos. And it should be self-explanatory of how I treat it. And now we move on to, and also you're going to follow the handout throughout this whole presentation, as I encouraged you early on. And there might be a little bit more information in the handout than is in the slides. Okay. And then the pattern that can be very challenging, which is hyperflexed coccyx. Now, I submit to you that most coccygeal injuries are a side bent tailbone. Okay. And the good news is most of those respond well. And regarding the whole population of acute coccygeal pain, most of them respond very well to conservative care. So that's the good news. And they respond to a variety of things. But 10% of them do not. I find those that have absolutely severe pain do not seem to respond to manual care and go on and have surgery. And of that, one study showed 90% of people respond very well to removal of the coccyx. There's such thing as a partial removal, but the ones that actually do the best are the ones that have a complete removal of the coccyx. Okay, nice article in JOSPT, Journal of Orthopedic and Manual Physical Therapy, Marinko and Pecci, 2014. Okay. Hyperflex, birth trauma can stretch the ligaments or damage the ligaments. So initially the injury is an extension, but then they deliver the baby and then it recoils anteriorly and there's not enough ligamentous integrity, and pelvic floor spasm, muscle tone pulls it into hyperflexion. Excuse me. You can also fall symmetrically onto your buttocks, hit the tailbone, and drive it into hyperflexion. Pardon me. The sit and stand lateral radiograph was developed by Dr. Main. And I believe he developed that in the late 80s. Although the article I'm referring you to here is dated 2002. And if the mobility is greater than 25 degrees, then that is positive for excessive mobility, excessive flexion mobility. Hyperflex coccyx symptoms, local tenderness is self-evident. It is typically much more symptomatic than the other patterns. Considerable midline and deep discomfort on the laterally as well. Vertical pressure to the tip of the tailbone reproduces pain. Pain with sitting, of course, worse with soft structures and low structures. Pain going sit to stand, pain leaning back because you tend to put more weight on the coccyx leaning back. Pain with multi-directional movement, but especially PA stress greatly enhances it. Pain with bowel movement. Here is a treatment video. Once in a while, you're lucky enough that the person's anatomy allows you to externally palpate underneath and capture it. And then with your thumb, you capture it. And then you traction it inferiorly and then posteriorly. And that's shown in the video, the technique of mobilization. Others, you have to use a lubricated glove sterile technique. You want to show them that you're doing the sterile technique. You want to make sure they're not anxious, they understand the technique, they've given you consent. Any indication of a little bit of anxiety, you can say, well, do you want to hold off on that? We can try soft tissue work, you know, and you can do the ice and etc. at home, and on your next visit we can discuss it again. You know, find a smooth segue if you sense any discomfort with them doing the procedure. Luckily, some people have anatomy that when you get in, you can easily get anterior and feel very confident that you are capturing it. Unfortunately, some of them are so deep in that you just can't get there unless you have a very long, you know, crooked finger, which I don't have. So women's pelvic floor therapists may do an anterior approach to treating the tailbone. I hope it involves, you know, not just pushing it posteriorly, but with the opposite thumb or finger tractioning the tailbone into distraction along with pushing it back into extension. Okay, the distraction is an important element. All right, so there's some video links and there's a little bit more in the book as well. My most unfavorite type of coccygeal injury, because they're very challenging. And if nothing helps them at some point in time, and it's greatly interfering with their quality of life, then surgical excision makes sense. There are some emerging techniques with injection, but very little data. And there are at least 2 reports on using cement to stabilize the segment. And I think that's described more on in the intersegmental joints. So anyway, some emerging techniques. All right, keep your eye on the literature. It's always changing. Next week there'll be an article. It's not in this presentation. So, all right, a little bit more. We already discussed that. Use a lubricated glove. Very gently press. So you're pushing into the sphincter and you just leave a little tiny pressure there. Let the body realize you're there. Let the body analyze it, or the nervous system. Go in ever so slowly, ever so slowly, ever so slowly, so that the person is not intimidated. And it's a very tender area. So just slowly, gently, and it might take 2 minutes to actually get all the way in and ready to do the treatment. Contact the anterior surface of the coccyx. The thumb, on the other hand, can contact externally, and that assists you in tractioning the coccyx inferiorly towards the feet. The client is lying prone. Okay. Sorry, I lost my place. Sorry about that. So yeah, so you're going to traction it inferiorly for about 2 minutes. Okay. And the first 30 seconds are traction to maximize distraction. And then a minute and a half, you maintain that traction and go into hyperextension. Let's see. Very small force. Okay. So we want to use probably 3 to 5 pounds of force. How do you measure that amount of force? Bend your elbow, use one finger and just push it to get the elbow to bounce a little bit. And that's about the amount of force. Okay. Less is more. Okay. And then slowly exit it. Retest mobility, retest tenderness, have them sit, stand, see how they feel, explain it's a process that healing might take place over a period of time. And in a couple of weeks, they may feel much better. They might not have immediate benefit. They might. Don't be discouraged, but also teach them how to manage it, put some ice, pain cream, lifestyle changes, coccyx cushion, all of that stuff. Okay. All right. So there are some additional resources. So coccyx.org is a very nice website, and you can list yourself on it as a practitioner. There is a Facebook Coccyx support groups. There are workshops, webinars, and online courses. Mentoring is very helpful. Lots of literature on PubMed, ResearchGate, academia, APTA. APTA Pelvic Academy is a good resource. You can join them. Pelvicguru.com is very good for pelvic pain, which can be much more than coccygeal pain, of course. International Pelvic Pain Society. Pedro, the physiotherapy evidence website. I have a book, Treating Sacroiliac Joint Dysfunction, Lumbopelvic Pathomechanics, blah, blah, blah. And I cover the coccyx treatment there as well, but certainly in this presentation, cover it in much more detail. But you also want to be able to treat the whole region as well. So that can be a good resource. Dr. Foy is an expert on the East Coast, and several things were taken from his book. And he sometimes offers a free copy of his book. So that's good to know. And you can follow him on Facebook. And there are resources through him at his website on injection, medication, patient tools, pain drawings, infection, etc. And that's included in his new patient form. And you may want to adopt some parts of that for your own clinic. You can find that on tailbonedoctor.com/forms. Okay. And again, also coccyx.org. There are some medical papers, and I accessed some of those somewhat recently. And then also I have some articles and writings posted on the Hesch Institute website and also on the Jerry Hesch YouTube channel. And let's see, okay. But realize I used the wrong terminology prior to January 2023. I don't know how it happened. I have no idea. Others do it as well. They see the tip pointed left, they call it a left side bent coccyx, and that's wrong terminology. I hope my new terminology is more clarifying and easier to use, okay? And then the Hesch Coccyx tool, you can reach out to the Hesch Institute, info at Hesch Institute. I would only use that on patients that are touch averse, okay? So it's very rare that you would need such a thing, but it's out there if you need it, okay? All right. Yeah, there's some details. Do you want to, you might segue if the person seems timid about being treated for a side bent coccyx or an extended coccyx. The tool is good for that. You can't use the tool for hyperflex. But you could say, well, we could use this Coccyx tool, and see if they want to segue into that and be more comfortable. But if not, defer care. Okay, and that's just a demonstration of me using it on a coccyx that purportedly is hyperextended, and it involves just traction inferiorly, and then also a little bit of anterior force. I would be using it for about 2 minutes. Okay. And then that's how I would use it for a tip pointing left restricted coccyx. Well, it's redundant. I meant to pull one of these slides. This one, I don't like that little line there, so forgive me. Lots of mea culpas when I present. So then there is a wonderful video. I highly recommend it for you and your patients. I promise you, you will learn something new if you watch this video, okay? I designed that in 1981, used to sell it with beautiful upholstery, but decided I like clinical work over upholstery and soft goods. And later on, someone else made a bunch of it. Okay, and then I also made a very nice bigger chair than the Balans. It was even more comfortable. I did a research study in PT school showing sitting comfort is enhanced when the hips are higher than the knees. And I still see, like every month somebody makes a new chair, new stuff going on, right? A cutout for the coccyx, it's good, okay? But you see the seat pan with a negative slope where the hips are lower than the knees. I'm like, oh my gosh. Okay. Sit stand desk can be very helpful. stool for them to put their foot up on intermittently can be very helpful to standing. With respect to an office chair, it has to be tall enough. You may have to buy a tall gas cylinder to get the seat height up correctly for a tall person. Well, I have over 70 references. You owe me a Starbucks. If you have any questions, reach out. I am very accessible. Okay. Congratulations. Hard work. And you got this. Trust your hands. Very soon, you're going to find this work to be second nature. Trust the process. And after you pass the post-test and you are awarded a certification in the Hesch approach to treating the coccyx, you can then email your information to the Hesch Institute, and you will be put on a list of certified practitioners. Anyone that sponsors my work, the PESI rehab course, they can't share your data with me. So the practitioner has to tell me, I'm certified now. I want to be on your list of certified practitioners, and then we can make referrals to you. So send it to info@heschinstitute.com. Please don't forget the spelling of Hesch is H-E, S like Susie, C as in cat, H as in Henry, heschinstitute.com. 2 more slides. Don't go away yet. All right. So do include your full name and title, such as, Mary Jones, DPT, etc. Business name and physical address, business phone, business website, business phone number. I guess I'm redundant again. See, another boo-boo. But yes, I know it's all on your website, but clients want convenience. So if you can give them all that info, the bottom one should have said email. Please give them your email as well. All right. If you make it easy for them, they'll be happy and they'll utilize your services. Okay, please help us promote the work. We're a small entity. Word of mouth is very helpful. Please recommend us to your coworkers, your colleagues, and your state chapter education committee. A recommendation coming from you is so much more effective than us trying to toot our own horn. Please post feedback on the Hesch Institute website near the bottom of the homepage, or in Google review or any other relevant resources. Look at the other boo-boo 2 little periods at the end there. If you can help us in any other way, please reach out. I have folks that are helping in various ways, just giving us a small amount of time each month. Research, if you can do even case studies, they're so helpful, so needed. If we can help the PT schools learn more about side bent tailbone, and they can go on and do more research, more people will be helped. Very few people know about side bent tailbone, and same for rotated. Perhaps you can recommend the topic for research and dissemination to the students at your local PT program. Maybe you can lecture on it, and together with a small effort, we can make a big impact. Thank you very much. The end.